to the next is a debate. The first speaker, this is on the resectable locally advanced lung cancer. The first person will be Dr. Sudeep Das from Kolkata. He will be speaking for concurrent chemoradiation followed by IO. It is over to you, Dr. Sudeep.
Thank you, sir. Thanks to the organizer. Me and Dr. Sandeep Ishi will be debating on the topic of resectable locally advanced non-small cell lung cancer, CTRT followed by IO versus perioperative IO. So, because this is a mixed house of audience, so my disclosure of conflict of interest is that I am a medical oncologist. And I am supposed to talk on CTRT followed by IO. So from this slide you can understand that how survival drastically drops down from 50% to close to 30 to 30, less than 30% when the stage is progressing from stage 2 to stage 3. So if you define that what is resectable and locally advanced, we should rather talk centered around stage 3, not stage 2, because stage 2 are upfront resectable. So we should talk about focus in stage 3. And what is the burden of stage 3 in our disease, in our country? This is the data from UK, and you will see even a country like UK, stage 1 and stage 2 constitutes only 3.5%. Then you will understand that how dismal will be the data of India. So a large chunk of our patients come in stage 4, and of course stage 3 and stage 3A and 3B, they constitute the larger volume. So a good chunk of patients are stage 3B, which are 30%. I hope our experiences are also same in India. Most of the patients will be in stage 3B. So what should be the strategy for these patients? Now, stage 3 is a heterogeneous group. All patients are not, all stage 3 are not same. Here we see stage 3A, which are broadly resectable, but stage 3B, only less than 5% stage 3B patients who are resectable in the data published by UK. And even in stage 3A, less than 22% patients were resectable. So this is the scenario in UK. Now what will be the scenario in India? So the patients who are unresectable, particularly unresectable stage 3B, we all know that the typical definitive chemoradiation, we call it definitive chemoradiation, but the median PFS was not very great. It was somewhere around 10 months to 12 months. And the median overall survival was, across all the trials, it was somewhere around 2 years. So there was a lot of scope for improvement, and here comes the landmark trial, Pacific trial. We, I think 3 or 4 previous speakers already showed these slides, so I'm not going into detail. The salient points of this trial is that all the patients were unresectable. Please note unresectable, that they were not resectable. They were unresectable patients, and the patients, they were post chemo radiations. They were treated with durvalumab maintenance for 1 year, who did not progress. Now see the patient characteristics. The strength of this study is that no stage 2 patient in this trial. 50, more than 50% patients in stage 3A, and a large volume, 45% patients are stage 3B. So such as the adverse risk patients were more in this specific trial. Even after that, look at the PFS and OS. The PFS curves are getting separated widely, and if you look at the OS data, you'll see, first look at the median follow-up time. We have 5 years overall survival data. There is a 5 years OS benefit of more than close to 10%. The hazard ratio 0.72. So this is the first and only approved IO to demonstrate 42.9% OS at 5 years. And this OS benefit is seen across all the subgroups except PDL1 score less than 1. If the PDL1 score is less than 1, you will see the hazard ratio is on the opposite side. Rather, it is actually detrimental, 1.15. Okay, and if it is more than 1, then yes, it is helpful, but the most of the benefit is actually driven by the group who are PDL1 more than 25%. So that is the group who are benefiting the highest. However, if you see across all the stages, stage 3A and stage 3B, in both the hazard ratio is favoring for durvalumab maintenance. Now we have some real world data also. This is not a randomized controlled trial. My previous speaker, Dr. Minit, has already showed you the data. It's a large data of durvalumab maintenance real world data. Here the median PFS was 24 months. More than 40% of patients were estimated to be alive and free of progression at 3 years. And the patients who got started with durvalumab within less than 42 days after the radiation, they benefited the maximum. However, why so impressive data? Because some of the patients were in stage 1 and stage 2 also. And if you see, even in this data, 50% of the patients were stage 3B and stage 3C. I want to hear from my colleague Dr. Sandeep Ishi that in what the trials of perioperative IO, how many of the patients were stage 3B and stage 3C, where it's in Keynote trial it's 15%, sir. In Keynote trial it is only 15%. So 25%, and one of the largest trial, Keynote trial with Pembro, it was 15% only. So this is the overall survival. More than 16% of patients were estimated to be alive at 3 years. And this is the data in nutshell to be presented by Dr. Ishi. So this is the Checkmate 816. This is the first trial, love at first sight, with a huge pathological complete response, 24% path-CR rate. And then came the Checkmate 77T, just the full paper got published this year in NEGM, event-free survival benefit of 20%. But please note, what is the median follow-up time? And they are actually reporting at event at 18 months, event-free survival benefit of 20% at 18 months. No OS data till now. This is Adjuvant trial where the drug was durvalumab, perioperative durvalumab. Even in this trial, sir was telling that stage 3B patients were 24%, where in the CTRT followed by IO maintenance trials, large chunk of patients were stage 3B patients. I think that they were somewhere around 50% patients were stage 3B. And so this is the median follow-up time in Adjuvant trial is 11.7 months. And if you see that there is benefit across all the stages. This is the Keynote 671, what I was referring. Here you will see that in stage 3B patients were represented were only 15%. And with that favorable group of patients, the results they got published, the 2 years overall survival, some new benefit around close to 3%, but they just recently they published their interim analysis OS data. And that showed that the hazard ratio for OS 0.72. However, the OS benefit was shown in all the stages, but my valid point is that you can't compare mileage of these two motorcycles when they are riding in two different scenarios. One is a village, a road, and a highway. Okay. So, and I will be expecting not in this lung master class, maybe after 3 or 4 lung master class, after 3 or 4 years, when all the perioperative trials data will be more matured and we'll see the OS data. However, in this lung master class, I can show you that mature data of OS of Pacific trial that we have already available with us. So, for take-home message for students that stage 3 locally advanced lung cancers are not a homogeneous disease group. You should choose your treatment according to your patients. If a patient is resectable, fine. Perioperative chemotherapy and IO is valid options, and there is no debate in that. But if the patient is stage 3B and most of them are unresectable, then upfront the strategy should be decided in a MDT upfront and treat them accordingly. And last, on a lighter note, that whatever you treat with, you cook paratha or you cook, dal tarka, we the medical oncologists are always here to put some butter on that. That is IO. Thank you.
Thank you.
Thanks to organizer giving this opportunity. And my talk is made easy by Dr. Sudeep himself, because he already mentioned when there is a operable, there is a definitely role for perioperative. So I think I can conclude here only. Whatever the data he mentioned about सर 10 मिनट अभी दिया है, इतना दूर से आया हूँ, कुछ तो करने दो. Okay, so this is the advances in adjuvant and neoadjuvant systemic treatment in resectable NSCLC. Before 2010, there are a lot of trials which establish the role of adjuvant chemotherapy, and there are few about the neoadjuvant chemotherapy. But after the 2020, there are a lot of shift in treatment which targeted therapy and immunotherapy is incorporated along with the chemotherapy in adjuvant setup like Pearl, Keynote, and Empower, and there are targeted therapy like Elena and Ardora. And along with that one, there is a neoadjuvant and perioperative lot of trials about the immunotherapy along with the chemotherapy. Checkmate 816, Keynote again, and Checkmate 77. So basically, most important, immune checkpoint inhibitors. Now they want to be in front row, and why not? So the rationale of neoadjuvant therapy, as we all know, the treatment with immune checkpoint inhibitors therapy, they activate the diverse set of T cells which acts on the antigen released by the cells, which is most important when we start in NSCT setting. And then with surgical resection of the tumor, which is already has a good effect with immunotherapy, the remaining systemic anti-tumor response also from the activated T cells that remains after the setting in adjuvant setting also. So this is a, we can say a phase 2 landmark trial in a stage, in phase 2 landmark trial in neoadjuvant chemo along with nivolumab versus chemotherapy. As rightly say here, we are checked for stage 3A and B, and with primary endpoint result of pathological complete response. In morning, by Dr. Monica, we have seen a lot of things like PATH-CR has a good result in prolonging the patient surgical outcome and AFS. Obviously, OS data is not yet mature. So study design, as we all know, in experimental arm, nivolumab along with paclitaxel, and then control arm only chemo, followed by surgery within 3 to 4 weeks. Adjuvant treatment, nivolumab, the dose is 440 for 6 months versus observations, and then follow for 5 years. So endpoint is PATH-CR. Secondary endpoint is major pathological response, along with there is a delay in or cancel surgery, length in hospital stay, surgical approach, and other safety profiles. So 90 patients treated, 86, 4 are excluded. Experimental arm, this is 2:1. So 57s in experimental neo chemo. Out of that one, 53% got resected. In control arm, out of 29, only 20 get resected. So if we see the summary, almost 93% patients got definitive surgery, and in chemo arm only 69% got surgery. So patient with definitive surgery is definitely much better with the immunotherapy plus chemo arm. The primary endpoint patch CR is also definitely 36.8 versus 6.9, very good. The major pathological response also very good, 52 versus 13.8%. The overall response rate is also significant, 75% versus 48.2%. The predicted biomarker response patch CR to neoadjuvant neo plus chemo, the patient who achieved patch CR has higher PDL1 expression than patient who did not. So less than 1% has only 15%, where more than 50% PDL1 has almost 61% of patch CR. So the conclusion, confirm the superiority of neoadjuvant nivolumab plus chemotherapy combination in patient with resectable stage 3A and B. The significant improvement in patch CR, maintain tolerable safety profile, and did not impede the feasibility of surgery. So the options of immunotherapy, there are, as since yesterday we are discussing, there is a perioperative, neoadjuvant only or adjuvant only. So here we are concentrating on the perioperative, that is Keynote 671, agent trials, and NADIM 2, which I already discussed. So the important trials here is Empower 30, Agent, Keynote 671, and Checkmate 7070. So this is Checkmate 7070. Here they are specifically mentioned about the in stage 3 resectable. This is a trial design. I'm not going to in detail, we all knows. So the primary endpoint event-free survival is like 70% versus 50%, which has hazard ratio is 0.58. The patch CR is also significant, 25.3 versus 4.7, and major pathological response is also significant, 35 point versus 12.1. They are specifically looked into the N2 disease, stage 3 N2 versus also along with the stage 2 non-N2, that is a T4 lesion. And here in both the scenarios, the event-free survival is significant, 70% versus 45 and 74%, 62%. And then not only this is randomized, but after definitive surgery also, the same, event-free survival is definitely better in neoadjuvant immuno along with chemo versus chemo only. They are again looked into the single station versus multi-station, which is again shows significant improvement. The safety summary, except the discontinuation, all adverse event and treatment-related adverse event, which is slightly more in the neoadjuvant immuno plus chemo versus chemo. Other safety things are almost similar in both the groups. So the key take from this trial, that patient clinical benefit in the clinical stage 3 N2, stage 3 N non-N2 patient. The surgical feasibility is also more, 77% in neo versus 73% in placebo, and also in non-N2 also the surgical feasibility is 82% versus 79% as a definitive surgery, and numerically higher with neo versus placebo. Patient with N2 and without patch CR improves the event-free survival after surgery with neo versus placebo. Perioperative neo shows similar safety outcome between N2 and non-N2 stage 3 disease. So as then the remaining 3 trials, I'll just briefly go. That Keynote, we all know this is the study design. The event-free survival is at the 24 months, it is 62% versus 40% with hazard ratio 0.58. The perioperative things, event-free survival is not achieved with 17 months in the chemo arm alone. And overall survival, as we say, yeah, initially it was very similar in both the groups. 12 months it's almost similar. In 24 months it's marginally different. But as if you see, the curves are getting widely separated, and at the 48 months the survival difference is 67% versus 51%, with hazard ratio is 0.72. And again here the PDL1 more than 50% shows better response compared to the less than 1%. So FDA approved Pembro for stage 2, 3 at any PDL1 level. This agent trials, again, this is the study design, we all know. The primary endpoint is AFS and patch CR, which is, as we see, over the time, it is widening the curve, 63.3 versus 52.4% at the 24 month. And patch CR rate is also significant, 17 versus 4.3. The similar we say with the patch CR central lab with minimal major pathology response. So if we combine all these three trials, Agent trials, Keynote, and 70th, we see a good path CR with the Neo versus chemo and chemo alone. The major pathological response is also significant. Surgical feasibility improves with the immunotherapy. When median EF is also, most of the immuno trials is not reached versus definite in chemo trials. Median OS is not mature in most of the trials. Completion of adjuvant OA is also better. And grade 3, 4 side effect is almost match. So if you see similarly, in neoadjuvant only, even though 100% patients got surgeries, but the people who are able to receive IO as the adjuvant is only 84%. So it's like a similar kind of proportion patient with go surgical outcome. So PATH-CR is also very good in a neoadjuvant setting. So this one, and which kind of patient will benefit with adjuvant therapy from the Checkmate 816 and Keynote 671? We know the patient who respond better with major or complete path response is better with adjuvant therapy. So neoadjuvant, adjuvant, or perioperative data appears suppose with peri-op, but more lung data is needed, and additional adjuvant therapy after neoadjuvant therapy. The preliminary data suggests that group of patients definite who have either PATH-CR or major PATH-CR. So that all we shows that neoadjuvant is definitely better compared to the adjuvant alone. Thank you.
Thank you, Dr. Sandeep. It was a nice.
The message should go like that. No perioperative IO trial showed that it is making unresectable patient resectable. That data is not available till now with any trial. So a patient who is unresectable may be treated with CTRT followed by IO maintenance, and a patient who is resectable, I agree with Dr. Ishi that perioperative chemo, IO and surgery should be the standard.
No, the debate is mainly on the resectable now.
Yes.
Thing is that. So, so basically, I think my concluding remarks will be basically on if you have to have a patient who is stage 3, to assess whether it is resectable or not resectable itself, you have to have a multidisciplinary approach as very important. Involve a pulmonologist, involve a thoracic surgeon, medical oncologist, radiation oncologist, call the pathologist also, molecular biologist. Everybody should sit together. I think we should have.
And the decision should be made on day 1, I think.
Day 1, correct. So if you say it is resectable, I think there are good data to go for a neoadjuvant therapy. Now, even though there are no matured overall survival data with immunotherapy, but looks very promising. I think we should look into that one, at least a subset of patient where PD-L1 strong positive and good performance status, where it is resectable. I think we should look into that.
We should complete the evaluation part, whether you are doing EBUS, whether you are doing midostenscopy, whatever, come with the data in MDT and take the decision on day 1.
And if it is unresectable on day 1,
yes,
I think you had a very good data on the Pacific trial, so there is no debate on that one. So resectable, I think we should have to work out properly and take a decision within the multidisciplinary team rather than individually getting things. Thank you, sir. Please, sir.
Time is there. Thank you, Doctor.
Yeah, please.
There is no debate.
No
right,
debate
there is no debate.
Thank you, Dr. Shekhar. Example for example, in esophagus and rectum, the surgeon sees it is resectable. We go ahead at the CTRT and the surgeon resects. Right. Coming to the lung, if it is resectable, the surgeon goes ahead with the resection. He doesn't wait for a immuno or a CT to be given and followed by resection. Surgical group.
No, I think that is what we have to change that thing now. We have to sit together and discuss. Any stage 3 disease should not go to any department just like that. We have to sit and discuss and then make out this plan.
And sir, in morning, Prashant sir has also clearly mentioned, if it is very upfront resectable, there is no doubt. But when there is a stage 3 comes, as the Keynote 770, they have nicely mentioned about the N2 with multi-stage or there is a single station, and then non-N2 stage 3. So a lot of this nicely data is mentioned that there is a role, and then it's actually accepted by the surgeons also that in stage 3, especially 1, where is this things, perioperative or a neoadjuvant will be a choice for them. It's better surgery.
For extras and the PGs who are there, or the extras, as of today, you say resectable chemotherapy or go ahead with the resection. Yes,
Sir, even for stage 2, even for upfront resectable stage 2, we should recommend perioperative chemo IO because okay, checkmate data we have only with 3 cycles Nivo, we can achieve that much of benefit. Even in stage 2, because before these trials, what is the data of stage 3 of 5-year overall survival? Just 50 to 55%. It's not that great. So there is a lot of scope for improvement. Patient will recur. And if you see the forest plot of OS, forest plot of EFS hazard ratio, the hazard ratio is benefiting for even for stage 2 also.
So the margin of benefit may be less in earlier stages, but definitely in stage 3 we should have a debate and discussion before taking a conclusion.
Shekhar,
So
can I
yes,
make a
yes,
comment here?
yes, sir, please.
So I've been sitting quietly and listening to all the presentations. Please keep in mind that we have young, impressionable minds in the audience, and medical oncology, lung cancer treatment is not only immunotherapy. When they go out into practice, they will be able to use immunotherapy in 1 out of 5 patients they see. So we have to keep that in perspective, right? Thanks.